Good evening, everybody, and welcome to our series one of Strategy to Treat Complex Calcified and Bifurcation Symposium. We have amongst us very eminent speakers, and Dr. Dhananjay Kumar from Medica Ranchi. We have Dr. I.S. Monga, who is a senior interventional cardiologist from Command Hospital, Kolkata. We have with us Dr. Shomujit Shaha, who is senior interventional cardiologist, who is my colleague with NH West Bank, Howrah, and also will be joined by Dr. Shuman Chatterjee, consultant cardiologist, interventional cardiologist at BM Birla Heart Research Center, Kolkata. So, as we all know, that um, bifurcation and calcification are two very complex areas in the PCI scenarios. And besides the different technologies which have evolved in the last 4, 5, 6 years, uh, these are the very, very difficult ones to treat. And of course, in the bifurcation, we also know that strategies which we take are dependent on so many factors. So let's start with Dr. Uh, Promojit Shaha he's a senior interventional cardiologist at NH West Bank, Howrah, and he's going to speak on um, a case with a bifurcation. Over to you, Dr. Shaha, for your presentation.
Good evening, sir. Good evening, all the eminent speaker today we have, and it's a great pleasure to present my case. I'm just have few seconds to share my screen. So, as Sam mentioned, I'm just going to present one of my case of left main bifurcation PTCA. First, I'm going through the history of the patient, and this male patient who is 51-year-old came with a chest pain, which was actually a late presentation of anterior myocardial infarction. Echo showed some mild LV systolic dysfunction, and there's ST elevation in anterior precordial leads. And this angiography was done as a when the patient arrived, which is showed that critical double vessel coronary disease with left main coronary disease, and angiographically it showed the distal left main shows some kind of 50% of stenosis, and proximal LAD shows 90%, whereas osteoproximal LCX showed 90% stenosis. So our plan was upfront bifurcation stenting to left main to LAD and LCX. I had this right femoral artery and venous access with 7 French catheter, and then I did one angiogram first with 6 French Judkins diagnostic catheter. Then I took the guide catheter after the angio, which is 7 French CLS 3.0, used run through wear, two run through wear for LAD and LCX. Balloon dilation catheter was as followed: 2.5 into 12 NC balloon, 2 into 12, another 3.3 into 15, and last but not the least, Riuri 1.25 into 10 millimeter balloon. I used 2 days for for LCX it was 2.5 to 48 millimeter of days, and for LED, left main to LED it was 3 into 38 millimeter of days. And finally, the port was done for left main with a 4 into 8 millimeter NC traveler balloon. Now I'm going to present the angiogram. This is the angiogram which showed this LCX is severely diseased at its osteoproximal region, extending into large OM. LAD is also showing some disease, central MI in the proximal area of almost 95% stenosis, 95% stenosis, laden with thrombus. Two major diagonal, early diagonal D1 and D2, both are showing some disease at its osteoproximal, and there's a TIMI2 flow. This is to confirm again that LAD deletion is proximal and L6 has osteoproximal, whereas left main has distal at least 50% stenosis. Next is the latment, how it looks like in the spider view. As I have mentioned, it's confirmed by this view, the latment distal here, and this LCX and LAD. Next, angiogram done on RCA, which shows minor disease. Next step was to wire those two vessels, LAD and LCX. First, I put the wire in the LAD, then we put the LCX, and this is the picture after wiring both the vessel, LAD and LCX. Then sequential predilation done to LAD as well as LCX. You can see here, and I use this 2.5 into 15 millimeter balloon in LAD, whereas in LCX I use 2 into 15 millimeter balloon in for predilation. Then after sequential dilatation, as I mentioned, LAD and LCX, then I again the predilation, as I mentioned. So LAD is quite opened up with this predilation. Next, I took one the balloon in LAD, which is 3 into 15 millimeter, parked inside the LAD for our step cross technique for stenting for dedicated bifurcation stenting. And we took one stent which is measuring 2.5 into 48 millimeter in LCX with minimal protrusion with Letman, whereas the balloon in the LAD was parked distally. After positioning of the stent, we just deployed it, keeping the balloon in LAD. And this is the picture after deployment of the stent in LCX. Next, after checking the LCX, whether any complication has arisen there in LCX, we just crossed the stent which was parked with the balloon which was parked already in the LAD, and then we took that leftment to LAD stent, and actually the proximal leftment to mid LAD was stented with a 3 into 40 millimeter days. Here we can see this stent is positioned from the proximal leftment to mid LAD, and it was deployed like this. After stenting to LAD, we did this proximal optimization. It leftman stent with a balloon of 4.4 into 8 millimeter NC balloon in high pressure at 20 millimeter of atmospheric pressure. Then after when pot was done, we just rewired this LCX, you can see here, and we put one balloon measuring 1.2 into 10 Ruri to open up the start at the side branch ostium. Next, after opening, after gradual dilation, post dilation of LCX with a 1.2, then 2.0, then 2.5 balloon was taken to LCX, and for LAD, we took one 3 into 15 millimeter NC balloon for post dilation of LAD, as well as for final for kissing balloon inflation. Here we can see this LAD was first dilated at the level of bifurcation. Then we did this position LCX was dilated with another 2-point balloon present in the LCX ostium, osteoproximal part. Finally, we did kissing balloon inflation, both at a time at a low pressure of 12 atmospheric pressure. This is the final. After that, we did one report in Letman, and with the same balloon 4 into 8 millimeter that we use for fast pot. And this is the final result when we took out the wire from LCX and LED in different view. This is the final result of Letman LED LCX bifurcation stenting. Both the faces are flowing quite well. Thank you for patient hearing.
Okay. Thank you, Dr. Shaha. So I would invite Dr. Monga to first make some comments on your case and then ask Dr. Shumon Chatterjee also to join in. Dr. Monga, would you like to make your opening remarks on this case by Dr. Shaha?
So it was a wonderful case, very well managed. I must congratulate Mr. Somajit for doing this case, sir. Actually, the strategy we could have used decay crush, sir, in the beginning, because we know both the branches are diseased. From we could have done, sir, first cross after doing this. Just wanted to, if we are doing it in different way, then we have to cross and do the first kiss beforehand. And after that, second crossing will be much easier. The balloon we are using 1.25 mercury. Instead of that, we can use normal 2.5 balloon also from beginning itself. We have done the first case itself. And second, when we are doing the keeping the balloon for crushing the stent, you park a little more distal in the LED. We could have kept in the left main to LED part so that crushing could have been easier. Otherwise, sometimes it may get stuck inside the LED vessel. If we are pulling, then we may damage the stent, proximal part of the stent. And thirdly, sir, imaging. If we could have used imaging, then we could have confirmed that we are doing very good optimization of the stents, both the stents. So these 3 points from my side, sir.
First question that you very correctly said, decay crush actually is little more number of steps. So it was a
Yes,
case
yes.
of acute coronary syndrome with TME2 flow. So it was late presentation, patient was unstable. So I prefer to go for this step crush rather. This is not mini crush, step crush. So that is the one reason. Decay crush definitely is good for, particularly said that 1.25 balloon may not be required at that time if decay crush was done, because before putting the LED stent, we could have removed the start from the side branch ostium. Then definitely. And for the second question that you mentioned, that balloon I actually kept little distal, maybe some other frame I have kept it there. So thing is that if I didn't want to put that balloon at the level of side branch ostium, in that case, when you use that decay crush, that we have to take some little lesser size of balloon. In that case, if you put at the level of ostium, and that will actually help to just precisely position the stent in the side branch so that it doesn't protrude much. But I took that 3 millimeter balloon to crush it properly so that I can take my all the wire and hardware there easily. And third question was another question
Or the
that
imaging?
imaging actually, sir, that time in 2022 we didn't have. Now we have IVAS, but that time we didn't have. We have to arrange for that, as it was not a planned case. So that is, I understand that could have been much better way to present this case and for patient as well.
Dr. Shumon Chatterjee, could you please comment on this case?
Good evening, sir.
Good evening.
My concern is left main with bifurcation. Definitely, imaging should be done. Though in our setup, corporate setup, where we work in, there is a budget is a factor. Definitely in our patient and IVAS and OCT is little bit of costly, and definitely as per recommendation, we should take imaging, the help of imaging, specifically in case of his. And in the previous question of Dr. Dr. Mongla. What I am
Monga,
saying,
yes.
yes, it's definitely Dr. Somujita is done a great job because it is in an acute setting. It is better to avoid decay crash. It is cumbersome procedure and wiring, rewiring, and again crash and again crash. So where the patient is little bit of um challenging case because he is a recent MI. So I think that is a good option to avoid decay crash or float in acute setting, MI setting. So I am definitely agree with Dr. Saha. And the second one is the IVAS. Though my case is also a layman case, I didn't
Okay,
do
okay,
IVAS
yeah.
because of this PA process,
Yeah, we'll
because of
discuss that,
the
Dr. Chatterjee.
uh,
Okay. Dr. Dhananjay Kumar, your opening remarks for this case, please.
Sir,
Good evening, Dr. Kumar.
good evening, sir.
Hmm.
Good evening, all the moderator and speakers. Uh,
Do you have any comments on this case?
Sir, I have joined very late,
Acha,
sir.
okay, you joined a little late. So, okay, so you just carry on then. So basically, as we know that by we do classify bifurcation by Medina classification or by the definition criteria. So this is by definition criteria is a complex bifurcation and superimposed on a ACS scenario. I think Dr. Shah did a wonderful job. Except that, I mean, as Dr. Chatterjee and Dr. Monga mentioned, that probably imaging is something which is not a kind of a luxury anymore. It is a requirement now that we do image. Particularly, Dr. Monga, do you think that the crossing into the recrossing into the side branch, where you are crossing, whether you are crossing proximally or distally, that is something which is also very important, Monga, with your imaging?
Yes, sir. Yes, sir. With the 3D bifurcation view, we can see, sir, whether we have crossed distal strat or proximal strat, sir.
That'll make a huge difference.
Yes, sir. Yes, sir. Yes. Long
And
term.
I think also the sizing of the more than the opposition, because I think this was ACS scenario. Opposition is probably not an issue, but without imaging in ACS scenario, we normally undersize the strength. So that is something which we need to also get help from the imaging. Dr. Shaha, would you agree with that?
Yes, sir. And not only the size, actually post-dilation balloon I have seen after doing the IVAS, definitely non-ACS case in much more stable patient, that we can way out of the imagination that we used to do some 2.53, it shows that you record 3.5 like that. Not always, sometimes. And that for distal and proximal crossing, as Dr. Monga said, that the 3D reconstruction image is required. Is it this what we have that in our cath lab IVAS, that doesn't have this 3D reconstruction images. So is it possible using that IVAS, not 3D one, that proximal or distal crossing can be ensured?
Sir, I was telling on OCT, sir, we can see.
No, he's talking about IVAS.
IVAS, normal IVAS actually,
Normal
not that
IVAS.
3D,
Can you
3D
see
reconstruction.
the distal or the proximal crossing of the side branch rewiring?
I don't think so, sir. It will be that useful. So you
Not
can tell us
clearly actually.
better. Yeah.
Yeah, other way is actually to keep the jailed branch and then actually cross it through that and take that as a reference. That can also be done sometimes. I think in a ACS scenario, this is a wonderful case. The only concern is that in ACS scenarios we undersize the stents, and that becomes the issue later on. But otherwise, I think you've done a wonderful case. Except that I think only if you did the decay crash is about 2 cases and 2 pots. Here you did only 1 case, so basically you are missing. You've just missed one step. Otherwise, it was actually a decay crash which you performed.
Yes, sir. But
Yeah.
for late is quick in, quick out. All
Yes,
the
yes, absolutely.
that is also very adrenaline rush is there.
Yeah. Dr. Chatterjee, in what scenario would you actually think about provisional stenting in the ACS?
in that case, I also, though there is a significant lesion in the 50%, more than 50% lesion in the ostium of the circumflex, I would like to prefer a provisional stenting and followed by a kissing vein impression in these cases. I do not take the risk of doing a bifurcation stenting in the scenario of ACS, though there is definitely significant stenosis is there. Rather, I may opt for a DEB for
Okay, so
ostium
in
of the
that
circumflex.
scenario, Dr. Chatterjee, if say you have opted for a provisional stenting and you have to switch over to a double stent strategy, once you're committed to a provisional stenting, what would be your strategy? What strategy do you like for your cases as a follow-up to provisional stenting for when you're converting it into a two-stent strategy? Would it be a T stenting or tap stenting or a reverse culotte?
I think reverse culotte. Reverse culotte would be the better choice.
Dr. Monga, would you agree with that?
Yes, sir. I also think so.
Would you also think that you would start off with the provisional in this particular case?
No, sir. I will start with two stent strategy.
Two stent, because I think by definition criteria, this is a complex lesion.
Yes, sir. Yes, sir. And it's a long lesion in the LCH.
Yes.
Definition criteria, according to definition criteria, all first two major criteria is matching.
Absolutely. Yes, yes. First two criteria and also the two additional criteria are also there. The only worry is actually in Indian patients, a lot of times we see even in ACS scenario, we underestimate the calcium content of the lesions. So that is something we have seen quite frequently, that even if it's the ACS on the clots is removed, still the balloon is not expanding. We're seeing melon seeding and dog boning. So that is a concern which is always there with Indian patients, particularly. So ACS is not so simple as we always think, because ACS is actually kind of positioned with calcium as well. Dr. Monga?
Yes, sir. Yes, sir. True, sir. We are finding calcium in a lot of these patients, sir. Day before yesterday only I encountered this problem, sir, because of calcium. So I had to use IVL in ACS, sir.
Yeah, okay.
Yes, sir.
So I think Dr. Shah, thank you very much for your presentation. Please do stay on, because you are all the expert panelists also for the subsequent discussion. Dr. Monga, are you ready with the presentation?
Yes, sir.
Okay, could you please share the slides when I talk about you. So our next speaker is going to be Dr. I.S. Monga. He is senior interventional cardiologist at Command Hospital, Kolkata, with more than 15 years of experience, and his main interests are in imaging physiology and complex coronary procedures. And I had the good fortune of actually interacting with him in one of the sessions before. And this time he's going to talk about a very pertinent question. It's about young patients who are presenting post-COVID without much cardiovascular risk factors with acute MI. So he has a cohort of patients where he has done published I wouldn't say a study, I think it's a report which are published. And he's going to talk about one of those patients who is a soldier less than 45 years of age. Over to you, Dr. Monga.
Thank you so much, sir. Thank you, eminent speakers, and thank you, Dr. Vinayak Dev, sir, for giving me opportunity again, sir. So today I will be presenting how OCT can help us in managing these young patients who are coming with acute coronary syndrome and they have got high thrombus burden. Actually, before coming here, I was posted in Chandi Mandir. So from there, I was getting a lot of young patients from Leh Ladakh area who was getting MI, but they're presenting very late to the nearest hospital. And after that, they were evacuated to me after 48 to 72 hours, depending on the availability of by-air evacuation, if weather is clear or not. So because of that delay, these patients were found to have high thrombus burden. Firstly, they were not thrombolized. Second, they were presenting very late. So because of this, I found a lot of high thrombus burden. So I started this study, and I'll be presenting only two cases, case scenarios, how I manage these patients. So first patient is a 28-year-old serving soldier. He's a non-smoker, no comorbidities. He's a young patient, and he's posted in altitude area for more than 1 year, last 1 year, at 15,000 feet altitude. And he suffered from inferior wall MI on 26th of November and was not thrombolized because he presented to the nearest hospital quite late. So he was air evacuated to us on 28th November because of some bad weather issues. So when he presented to us, he already had inferior wall MI with junctional rhythm and persistent SC elevation, and echo showed EF of 45%. So I took him for the angiography same day. I found that RC was 100% from ostium only. it was occluded. So this was the ECG on presentation to me, and we see first I did the left angio with the diagnostic catheter, found that it was filling retrogradely, RCA. Patient has presented to me after 48 hours. So there are collaterals. So I straight away took the guide with the wire in filter FC and then crossed with the wire. Then only took the first cine. We can see first shot. Some flow has, some trickling of flow has already started after wiring. Earlier it was 100% blocked with a complete thrombus occlusion. So I first made thrombosuction runs. So I could partially recanalize the vessel. We can still see some residual thrombus here. Did more thrombosuction, this red thrombus which was getting aspirated repeatedly. So did more thrombosuctions, and after this we can see there is still residual thrombus. So there are two options. One is we can put stent at this stage, but he was a very young patient, and I wanted to give DAPT for so long for these patients because they are employed after that to field areas where they may not have any access to the medicine and all. If I'm putting stent at this stage, I'm committed to that. I will have to give him lifelong medications. So I did what I did and did the OCT in the same setting, whether to find whether plaque rupture is there or not. With the residual thrombus, this was the OCT run, sir. We can see vessel is healthy distally. We can see all trilaminar structure is there. And if we are coming proximally, some plaque is there here, fibrotic plaque, and becoming more. This will be the area where we'll find. This is sideband. We can see the thrombus, residual thrombus still there with plaque erosion. There is no plaque rupture. This is the thrombus adherent to the wall. So I avoided stenting at this stage. So what I did, I gave a 24-hour GP2B3A infusion, and after that again 7 days LM2H I gave for this patient, and after that I found that vessel is completely clear when I did the check angio after 7 days. So there is no thrombus. OCT also I repeated, and there was no thrombus on that also. So we managed this patient without stenting. And the second case scenario is this patient, 33-year-old, again non-smoker, no comorbidities. He was posted in high altitude again, and he was suffered from anterior wall MI on 2nd of January 2021. His EF was 35% at presentation, and he was also not live, being presented very late to the nearest hospital. So he was evacuated to us on 3rd of January 2021, not 23, sir. Ongoing JANA on arrival, and he was immediately taken up for angiogram. So this was the ECG, sir. And after this, again, I took first the right shot. The vessel was not filling LED. So I took the cine with the diagnostic catheter only first. We found that proximal LED is 100% occluded after diagonal, small diagonal. So I crossed with the wire and did the thrombosuction run. After that, we decided to place direct stenting because there is a lesion here. After clearing the thrombus, TB3 flow has come. So in this patient, I opted for direct stenting. Still, I had to encounter slow flow, but I gave intracorneal adenosine, nicorandil, and again GP2B3A. And after this, I didn't post dilate in same setting. So I'll tell how OCT helped in this patient. After 72 hours, when I did the check angio, and this appears to be a good patent stent, but on OCT, we found that it was an underexpanded stent, as expected. Because as sir was telling, we can't access the area properly. Sizing without imaging, not possible in ACS setting. So expansion was only 74%, especially in the distal part, we can see. It was the underexpanded stent. It was not, opposition was not the issue in this case also. So again, this is, if we leave like this in this patient, they can come again with ISR. We can see this is underexpanded stent here. The proximal part expansion was good, but in the lesion where we could not dilate properly, and we had not done pre-dilatation also. This was unexpected. So did the post-dilatation with the 4.5 into 12 NC, and after that again did the OCT run. This was the final angiogram, and this time we could achieve 100% expansion. So another scenario like this we had encountered, where I gave just intracoronary TPA for this patient, didn't do any thrombosuction, or this patient also come very late to me, and after 72 hours. So I did just give through diagnostic action only, gave the TPA 1/10 of the dose, systemic dose, and after that I gave 7 days of LMB therapy, and next when after 7 days we did the check angiogram with the OCT. We found that there was only erosion, so we didn't stent this patient also. Similar to this is a very young patient who had come with anterior wall MI, and he had been thrombolized in altitude area. We had found borderline lesion here, but FFR was negative, but this was within 72 hours. But again, we did the OCT, we found that there was thrombus, and again there was a plaque rupture, so we had to stent this patient and post that. So this patient also, he was COVID positive. So this patient had osteoporox lesions, so had to do crossover stenting. Like this, we had done such stenting cross. We had done with imaging stenting. This was a data of 119 patients, and we did imaging and stenting in 87.5% patient we managed without stenting, and 45.1% patient who were not from altitude area overall, but they were young patients. They also didn't require stenting. So now we have completed 3-year follow-up of these patients, sir. So this is my case, sir. Thank you, sir.
Thank you, Dr. Monga, for these wonderful 4 cases. I'm sure that our panelists will have a lot to discuss. So first, Dr. Chatterjee, Shubhan Chatterjee, do you want to make any comments? This cohort of cases by Dr. Monga.
First of all, thank you, Dr. Mongla, for wonderful cases showing, and the wonderful from cases with thrombus burden, high thrombus burden, few cases, one cases with COVID positive case, and the cases are nice, and in some situation, the decision of not stenting, especially in first case where the delayed presentation, high thrombus burden, and no stenting. I think the judicious approach. And in COVID scenario also, the majority of the cases are mostly high thrombotic burden. In that cases, without stenting and GP2B3A infusion sometimes helps to resolve the thrombus burden, and patient in that cases patient can be saved without stenting. The metallic burden can be we can avoid the metal burden of the patient, especially in that scenario, high thrombotic burden patient, COVID positive patient. These patients are young patient, so it's a good approach. And second one is the OCT. Nowadays, OCT is a very useful imaging option, especially to see the thrombus, or is there any spontaneous dissection or proper apposition of the stent. I think OCT should be used, especially in high thrombotic burden cases. OCT is a little bit of edge over IVAS in acute setting. Thank you.
I have a question to Dr.
Yeah, Dr. Saha,
There is a second case, which is very nice actually concept. What are the criteria we can use to use this imaging not in the same sitting of in case of ACS, but after a few hours or days that you mentioned, that you did actually in that case, and nicely did.
In second case, the
in second case, what could be the indication of such approaches?
Like this first, when we did the thrombosuction, we could achieve the TME3 flow. But when we implanted the stent, then there was a slow flow encountered, slow flow situation. So we could barely come out with the use of adenosine and GP2B3A and nicorandil. We gave everything. So after that, we could achieve TME2 flow in the end. But at this time, if we start post-dilating, then I will can land up with no reflow. So that's why my concern was that if I am giving LM2H for another 72 hours, and before discharge, basically I wanted to make whether this with this post dilatation is required or not. So that was the concern. We have found we have done a separate substrate among these patients where we are doing direct stenting, and after that, almost 80% of these patients require post dilatation because undersizing is the main problem, sir.
And what was the that inflation pressure that you applied in that case for the stent deployment?
Stent deployment, I don't go very high pressure. I just go over 2 atmosphere above the nominal pressure. If
About the
nominal
nominal
is
pressure.
nominal is 11, I go to 13. That's all. I don't go very high, but inflation, I give a slow inflation and slow deflation also for these.
Definitely, deflation should be much slower.
Yeah,
And
because I think there are a couple of points here, because I think Dr. Monga actually has the liberty and the access to imaging. He did not go above too much high pressure. But in the era where we started our angioplasty in 1986-87, we had to go high pressure because we did not have the liberty of actually having any kind of imaging technology to size our arteries. So it was oculostenotic reflexes and whatever we used to think as a reference size we used to go. So LAD in Caucasian patients we had to do 3.5 and above, maybe 4 sometimes, and LCX and RCA similarly depending on where the lesions were. So in my practice, I used to start off with go high pressure, go up 18, 20, and then come down. And then, if required, we had to go for a post dilatation. But usually, in our practice, when we did not have the luxury of the imaging, we had to go high pressure to begin with. But nowadays, I think it is much more scientific because you exactly know after going in with your imaging how much did you achieve above the nominal pressure. So, Dr. Monga goes 2 atmospheres above nominal. What about you, Dr. Shaha? What is your approach?
Definitely, as you mentioned, sir, that we don't have a imaging always, and more so in acute coronary syndrome. So I usually do, and I have seen people doing that very high pressure, definitely slowly to build up.
Not for ACS. I'm just talking about the non-ACS cases. For ACS, I think Dr. Monga, which you mentioned, that you have to go very slow and try to dog bone the place if you can. Then your thrombus is actually, concealed within the wall, between the wall and the stent.
No, that expansion type depends on the stent type. Whether
Yeah,
it will
definitely, yes.
it will bulge fast in the periphery of
Yeah,
center.
yeah.
But usual cases, if I see at 12 atm of pressure that dog boning or that is gone, then we are very happy.
Yeah.
Otherwise, you have to go to high pressure, sustained pressure for 20 seconds or 30 seconds. If ischemia is not there, then we can go down gradually. Most of the cases we can handle with that, and with the OCT or IVAS at least, we can go very confidently in those.
Because this is a educational course, so we have to mention that when you are actually also deflating during ACS scenario, your deflation has to also very slow. You cannot just go for a negative
No,
suction straight
slower
away
than
because that will
inflation.
shower the thrombus again to the distal artery. So,
That will
Doctor,
actually create the venturi effect and create the thrombus
absolutely,
will be
yeah.
taken
So
into
it's a
the.
slow inflation, slow deflation for the ACS scenario. Dr. Dhananjay Kumar, your comments on this wonderful series of cases by Dr. Ponga?
The 2 cases, sir. The first case in which he have not given a stent, it was a beautiful case. In young case, today morning we have performed a PCI in a patient of 26-year-old male with inferior wall MI having lots of thrombus, and unfortunately we don't have imaging today. That's why we have put a stent over there. But definitely if we have imaging, we could have avoided that extending to that point. I definitely accept that. So it was a wonderful and lesson to at least for me. Yeah, this should be the year. And in the second case, sir, in cases of ACS situation, definitely the segment was short. Sir was have given a small stent. So in that case, you can go up to higher pressure also. In the such situation, it is definitely a low risk for slow flow or no flow. But in a situation where you have a high thrombus burden and the segment is longer, I used to avoid high pressure NC ballooning because it almost always causes either slow flow or sometimes no flow, and the both the circumstances are definitely detrimental for the patient. It definitely causes a different outcome to the patients. I have lost one to I think at least 10 of the patients, either they developed slow flow, no flow at the table, and they developed VTPF and electromechanical dissociation, and it was hard to revive them. So it was my unfortunate experience. This might not be with you all, but I usually avoid high pressure NC ballooning in cases of primary, particularly in cases where I am doing LAD and in cases with high thrombus burden. I usually avoid. I took the patient 48 to 78 2 hours later and give high pressure up to 26, 28, even opium balloon, whatever is needed. But I usually avoid. I honestly accept that I don't do that.
Yeah, so I think the take-home message here is actually that, I mean, the imaging is such a useful tool, and in making so many decisions clear. Without imaging, it will be very difficult to take a call of not stenting a MI patient. So this is something which we have learned from Dr. Monga. Only thing, one point, Dr. Monga, do you have any literature on a review to all of the panelists about the intracoronary TPA versus systemic TPA? Do you have any advantage? As far as I could recollect, we during our times we did not actually, because we did a couple of studies in. I can't remember which study it was. It was a multi-centric trial where intracoronary lytics were given versus systemic lytics, and we did not find any difference. So, what is your experience, Dr. Monga?
The intracoronary TPA we are using with 1/10 of the systemic dose.
Yeah, yeah.
And if we are not having TPA, then we are giving tenecteplase. Again, 1/8 dose, sir, we are using, like 5 mg.
Is there any recommendations or any guidelines on this?
Sir, actually, I had a discussion with two of this thing. One, Dr. Shiba, I had met, sir. She was doing research on young ACS patients. And then another Dr. Vijay Kumar and Dr. Ajit Mullasare. Sir, they also were using 1/5 or 1/10 of those only, sir.
Yeah, but I don't think we have any guidelines or recommendations on these.
They are case reports only, sir.
Yeah.
But I could not find a long series, sir. Definitely data of
yeah, because I think it was done before during time when we used to in the 90s. I think there were a couple of studies which I was involved in where intracoronary lysis was given. We didn't have TP at that point of time. We had streptokinase and urokinase as well, but that did not show any difference between systemic versus the intracoronary stuff, even with antiplatelet agents also. So that is one point I wanted to talk. Okay, so we'll move on to our next speaker, Dr. Shobhan Chatterjee. He is a senior consultant interventional cardiologist at PM Birla Hospital. So over to you, Dr. Chatterjee, for your presentation. Please share your slide.
Good evening, sir. I will request ID team to share my slide on behalf of
Okay, Prashanjit will share your slides. Yeah. What are you talking about?
I will talking about in acute MI situation, left main stenting and provisional left main stenting.
Okay, very nice.
Next slide, please. So my patient was a 52-year-old lady, non-diabetic, normotensive, had a history of recent MI 3 to 4 days back, around 3 to 4 days back, managed conservatively outside, but patient came here with a post-infarct angina and echo shows mild to moderate LV systolic dysfunction with ejection fraction of 40%, but there is on echo, there is still preservation of the muscle mass is there. So we took the patient for an angiogram, which reveals there is a significant lesion in the mid LAD, along with a lesion in the distal left main and the osteoproximal LED. Circumflex is scheme of the circumflex is little minor disease or free of significant disease. Next slide. So she has a significant left main disease with an osteoproximal LED involvement, and a mid LED has a tight thrombotic disease. Ostium of the LCX has free of significant disease. Offer for CABG, but patient also denied for surgery and has taken for the angioplasty because of her ongoing chest pain. Next slide. So we took a 7-French gel with a wire keeping in the circumflex, and first we, next slide please. You can show the significant lesion in the distal to mid left main and the osteoproximal of the LED, and the mid LED is a tight significant thrombus containing disease. So because of high thrombus burden, we take the direct stenting in the mid LED lesion with a 3 into 16 millimeter days, followed by post dilation with the same balloon for 10 to 12 seconds. Next slide. Now we plan to do a left main to LED or LED stenting covering the osteoproximal portion of the LED. We position the stent and then a 3.5 into 12 millimeter disc deployed from the left main ostium to the osteoproximal LED lesion. Next slide. And followed by pot with 4 into 8 millimeter NC balloon. Next slide. Then we rewiring done and followed by in balloon inflation, and then the kissing balloon inflation with 4 into 8 millimeter balloon and a 2.75 into 12 millimeter balloon in the LCX. This is the kissing balloon inflation. Next slide, please. And this is the result of post KBI. And after that, we do a final pot with 4 into 8 millimeter balloon and a fairing or the osteoproximal of the left main stenting, that is a autoosteal fairing with a 4 into 8 millimeter balloon at high pressure. And this is the final result. And final result shows satisfactory result. LCX ostium also shows without any significant pinching. And post KBI kissing balloon inflation result is also good. Next slide, please. So I think there is satisfactory results, and in the scenario of acute coronary syndrome like anteroseptal wall MI, provisional stenting was done as there is no significant lesion in the osteoproximal circumflex. Next slide. Though I as per the recommendation, we should show the imaging, but somehow at that moment we don't have the imaging facility. So imaging was not done, but definitely this is in the left main stenting for the proper apposition of the stent and for the proper sizing of the stent, we should take the help of imaging. Now, next slide, please. Coming to the take-home messages. IVAS or OCT recommended for the left main PCI. POT is a crucial tip before kissing balloon inflation and during bifurcation stenting for re-entry and for proper inflation of the stent. Thank you.
Thank you, Dr. Chatterjee, for this wonderful case. So let me start with Dr. Monga. What are your comments on this case, Dr. Monga?
Sir, first of all, I congratulate Dr. Suman Chatterjee for very beautiful case and very well managed. Sir, actually, I wanted to say that in the when we are deploying stent in the ostial part of the left main, sir, we are using epicranial or allocranial view. That gives here it was being deployed in the allopodal view. Sir, first I think I differ in that sir part because I don't know whether we'll be able to cover the ostium properly or not of the left main by doing left main crossover stenting. The second part is that before deploying stent in the ostial part of the listing LAD, so I want to use cutting balloon because there is a lot of fibrosis there and fibers are like that. So we cannot open this with a normal NC balloon. So we are finding some waste here sir, in this patient also. So in the end also, after doing this thing, kissing balloon also, we could find some. These are the two sir, things I noted, sir. Sir.
Dr. Shah, your comments. Then we'll go back to Dr. Chatterjee.
Firstly, as correctly mentioned by Dr. Monga, that view should have been this epicranial to see the that ostium of left main flushing with the sinus of the aortic sinus, actually left sinus. So that is one thing we might miss actually, or we might protrude much more than we expect. And one more thing I want to see was that kissing balloon in LAD LCX was absolutely necessary in this case, as LCX was almost free of disease. LCX ostium actually is not much of disease. Was that
okay,
any,
Dr. Dhananjay Kumar, your comments, and then we'll go to Dr. Chatterjee. Yep.
Sumant Chatterjee, sir, I want to ask one question. Have you overlapped the two stents?
Okay,
No, no,
Dr.
no.
Chatterjee, your answers now.
So what was the gap between the two stents?
I think it is more than 6 millimeter, though it is a image without IVAS, I cannot say the length of the non-stented portion, but I think it is more than 6 millimeter.
What do you think about Dr. Shah's questions about not requiring kissing?
I think there is some amount of disease in the ostium of the circumflex, though it is not significant. And in left main disease, when there is a significant large side branch, it is better to do a kissing balloon inflation and for further number one for the proper opening of the stent, and if required in the next time intervention, if we required we have to go to the circumflex, then kissing balloon inflation will sometime help us. So that is another important technique, and nowadays without significant disease, kissing balloon inflation has some recommendation also. I think there are some meta-analysis are there. Their kissing balloon simultaneous kissing balloon inflation has shown a better long-term safety data.
but in that case, you have to prove that there is a start in that side branch ostium. Yeah, then only you can go for your second option. And firstly, if it is not visibly pinched, then we can do imaging or FFR. Most of the time, it will show negative. Otherwise, in ACS scenario, very difficult to decide that final kissing balloon, then port, and all those things. Anyway, good, very good case. It was properly managed.
Okay. And the another question is use of cutting balloon. It is a case of enteral MI with a high thrombus burden. I don't want to take the risk of dislodgement of the thrombus, and so I tried to avoid the cutting balloon. And definitely, I also use allocranial view to see the ostium of the disease, but somehow due to during the preparing, I lost that view. But I forgot to incorporate that view. But we have checked a podal spider view and the allocranial view, and after that we deployed the stent.
Yeah, I think
epicranial, not allocranial.
Yeah, I think the views must have been taken. It was probably not shown here. So I think the overall message, I think, is that we all want to use the KISS technique for ACS. KISS is keep it simple. So I think that is something which we always should follow. Now, about the pot, I think it's very important for the learners to also know that where you place the balloon is very important in pot. That you should not actually touch the crystal carina because you don't want the carinal configuration to change. So the pot should not come outside the proximal stent and it should not go beyond the carina also. So that is something which is very important in the pot. If I want to play the devil's advocate, can I ask all three of you that if your left main is short and you don't have a balloon of that size, what do you do? How do you pot? Dr. Monga?
So we can keep the proximal part hanging in the aorta, sir.
But would you still go with that? Say if you have a short left main,
yes,
and would you want the balloon this stent to come out? So it will be difficult to reintervene again, isn't it?
We covered the ostium, sir. Then we can bring the balloon.
How long are you comfortable with keeping it outside the ostium and hanging in the aorta? How long are you comfortable about? With what length?
Maybe 2, 3, 4 mm, sir, maximum. Because if this thing is 6 mm left main, and we can use we don't have 6 mm balloon. We can use 8 mm balloon. So 2 mm only will be hanging, sir.
What about Dr. Saha? Are you comfortable with that? Please unmute. Yeah.
Very tricky question. This is.
Yes, it is.
In that case, we have to put that most of the parts in the LED rather than putting it outside, because next intervention, the next person will have face absolutely disaster.
Nightmare, absolutely, yeah.
Absolute nightmare.
So, as such, we
not only that, if we lose it by the time, if we re-engage that, we can harm the stent. In that case, flow will be lost. So
yeah, I think it's a very difficult scenario, but it's not. It is a scenario what actually we sometimes face. It is not a very unusual scenario. So I think using a Zabo technique for the not missing the left main is something which we normally use. But I'm not a proponent of keeping too much of stent struts outside the left main ostium, because I think, as Dr. Shah rightly mentioned, it will be very difficult to re-intervene, rewire, and you can actually damage the stent struts by even engaging the catheter. You can still damage it. So I think it's a difficult scenario. It's not an easy scenario, but we do come up with these kind of things because it's a teaching course. That's why I wanted to mention this.
Actually, in those type of cases, the short left main, the main thing is that size mismatch in left main and LED. If you want to put that more stent, and then the LED will be over dilated, that is not actually we want. We have to take the stent accordingly. But one thing is that I have done few cases that 3 mm stent in LED can be blown up to 4.5. It's not officially, they are mentioning that it can be 1 mm more, but we have done, and other people also done. I've seen them doing some 3 to 4.5. That is also option. If you can just take a 3 mm stent with a minimal protrusion in the aorta ostium, and then we can dilate is 4.5. And I think that can be managed short left.
Here is a very important scenario. The reason why the provisional stenting is so very useful is when you have this kind of scenario, you can get away with the provisional stenting. If you have already committed to a bifurcation stenting, you'll have a lot of trouble doing a proper pot with a short left main. So here, I think the provisional stenting techniques are much more useful in bailing out from these cases. So I think this was a wonderful learning case, and I think it was very well done by Dr. Chatterjee. So we'll move on to our next speaker, Dr. Dhananjay Kumar. He's a very well-known cardiologist with Medanta Hospital, with Medica Hospital, Patna. Is it Medica?
Ranchi, sir.
Ranchi, yes. Sorry. We have met before, and Dr. Dhananjay, Medica Ranchi, yes. So, would you want to present your case? What is your case?
It is calcified lesion with left main bifurcation, rota ablation to both the vessels, as well as
you have got the whole gamut of things: calcification and bifurcation and rota ablation. Very good. So let's get on with the case then. Please share your screen. Maximize it.
Yes.
Yeah.
So this is about a 68-year female presented with ongoing chest pain. Her ECG was suggestive of non-ST-SCS.
Could you just
Vital
maximize the slide, Dr. Dhananjay? Just maximize it.
Go to the slide slow.
Go to the slideshow. Yeah. Yeah, there.
Sir. So her vital was stable. She was hypertensive but non-diabetic. On angiography, yeah, RCA was normal. LAD.
Slides are not moving.
Slides. This is moving in my. Sir.
Other panelists, can you see the slides moving?
No, slides are fixed. First slide you can see only.
Slides are fixed.
Yeah.
First slide you can see only.
Yes.
Okay.
Just share it again.
Okay. I'm saying. Is it okay?
Yeah, it's moving now. Sure. You've gone to the angiogram slide. Yeah, it is moving.
Sure. So right, RCA was normal. Left main was calcified, and the shaft was critically stenosis about more than 75%. The bifurcation point was also calcified and critically stenosed in LCX was almost totally occluded, and LAD was critically stenosed. So I initially opted the calcium from angiographic point. It was not looking so thick, although it was calcified, and but it was not looking thick. So I started with the slides is not. Okay, so I was able to cross the lesion of LCX and with the filter XC wire, and a simple workhorse wire put it in the LAD. I started inflating balloon starting from the 1.2, then 1.5, but after 1.5, the two balloon was not crossing the lesion, and it was coming back to the left main. So I decided to go for rotablation. I did rotablation to LCX first, then to LCX, and saw the flow in the LCX, and then rotablated LAD, and this was the flow in both the vessels after rotablation and adequate pre-dilatation to both the vessels. So yeah, so this is the on the left upper corner. Both the vessels have been prepared with the proper pre-dilatation. And initially, before the rotablation, my thought was to do DK crush, but due to the time consumption in both LAD and LCX rota, I now decided to go for the simple LAD and LCX stenting with Coulomb technique. So I deployed sequential stent, uh, what we usually do in full load. In LED to leftman to LED, I deployed a 4 into 20 stent, and I uh, took several images and to deploy it at the proper position in leftman, hanging a stent, 2 to 3 stent studs hanging to in the aorta with the proper covering of the LED stent, LED lesion. But at the initiation, beginning of the inflation of a stent, the patient coughed and the stent shifted proximally towards the aorta. But by the time I could have recognized this, the my assistant had already inflated it to 8 atmospheric pressure. So I decided to go it to the nominal pressure, and will do it later on whatever I can do. So, uh, but in the next few minutes, it was like definitely a nightmare for me. The catheter has lost its position and the wire is coming out. So ultimately, the wire and the whole system came out from the uh, left main, and now I have to re-engage the. Sorry, extremely sorry. Somehow I'm just showing it again. Showing. Am I audible?
Yes, you are audible, Dr. Kumar.
Okay. Okay. So, is my screen is visible to all of you?
No, it is not visible now.
No. Is it, sir?
Yeah, you can see
Is it
the
visible, sir?
slide, but it is not moving.
Okay, no, sir, it is not moving. I have not.
Yeah, okay.
So now I have to re-engage the my catheter, and now the stent starts outside the ostium of left main is so long, and it is distorted by the catheter, as well as it was hard to re-engage through the central lumen of the
Sorry,
stent.
sir. Please share the screen again.
Okay, okay, okay. Is it visible now?
Yes, sir.
Yeah.
Okay. So I have tried for several minutes to engage through the central lumen of the stent struts, but I couldn't. I started to engage at the ostium, the original ostium of the left main, and I crossed the wire through the stent struts, and now I started dilating the stent struts through sequentially, so 2, then 2.5 up to 5.5, and neither moving forward nor backward. Yes. So I sequentially dilated the states at the ostium, and then I did the post dilatation and final kissing balloon inflation, and took the IVAs of both the LAD and LCX as well as the left main ostium. Fortunately, the new ostium that I have created at the left main was normal. It was well covered with the stent studs. So, this was the final outcome, and it has been more than 1 year, I think, more than 1 year from, and the patient is doing good. She doesn't have any complaint right now, and fortunately, the new ostium that I have created is not creating any problem to the patient. So this was my case.
Okay, Dr. Monga, your comments, please.
Sorry, sir. Actually, I got a call in between, sir.
Okay,
Could
okay,
not
okay.
completely
So,
follow the case, sir. Sorry.
okay, so maybe Dr. Chatterjee. Dr. Shaha, your comments. Dr. Chatterjee, yes. Please unmute. Yes.
No, I think the cases was nicely done because it is a complex case, rotor ablation followed by stenting, bifurcation stenting, and followed by again IVAS for stenting. Nice case. That's
Okay. Dr. Shaha, are you there? Okay. So, Dr. Dhananjay Kumar, I think it was a wonderfully done case, and I think it was a very complex case, as Dr. Chatterjee and Dr. Monga also mentioned. So, all the things were taken into account. Probably, in this kind of scenario where you're using so much of hardware and so much calcification and bifurcation, what kind of imaging, Dr. Monga, would you use in these kind of cases? Would it density or IVUS?
Sir,
And
IVUS.
the reasons why?
I like to use IVUS in these kind of cases, sir. First,
Okay.
OCT has got advantage that calcium scoring, with the calcium scoring, we can plan the hardware. But
The depth of the calcium.
Yes, the depth of the calcium. That is the only additional factor that will give. Other than the rest, all we can see on IVUS only, sir.
Okay.
So I think I'll prefer IVUS still in this patient because we are coming to the ostial left main also. So that we'll have to dehook the catheter and will not be properly imaging with the OCT, sir.
So when you're doing a rotablation of two arteries, I mean, would you complete one artery, stent it, and then go proceed to the second artery for rotablation, or would you? What would be your technique, Monga?
No, sir. Rota will do one by one only, sir. We'll
Okay.
after that only we'll start sending, sir.
So once you do the rota, you start stenting, finish the stenting, and then go to another artery. So, Dr. Kumar, what about you?
Sir, when you are planning for a upfront bifurcation or stenting, it is not possible. You will go by one. It is you have to do the preparation of both the vessel first, and after that you will be able to do upfront bifurcation or stenting. So in this case, but yes, so of course you have to, when you are doing rota ablation to one artery, you have to be sure that that artery is flowing. If that artery is distally embolized and not flowing, slow flow is there, definitely you have to avoid the rotablation to another artery, because if simultaneously you will create a slow flow in both the system, definitely you have to suffer a lot of nightmare there. So that precaution I have taken, and I first saw the flow in the LCX. I did rotablation to LCX first, because LAD was critically stenosed, but although it was flowing free flow in that vessel, so if LCX was if slow flow was there in LCX, I could not have done rotablation to LAD. But it was flowing vessel, good flow, so that's why I opted for rotablation in LAD also. There is so much of concern. Now you have to think all the things. You cannot use rotablation in both two separate vessels in two different settings in a situation where your patient do not have much money. You have to think all these things. So definitely, sir, that's why I opted to do or rotablation to both the vessel. And in left main and bifurcation lesion, you are doing both the vessel is critically stenosis. You have to think about upfront stenting. Nowadays, I am opting in spite of bifurcation, critically bifurcation stent, a bifurcation lesion, along with left main lesion, I am opting crossover stenting left main to LAD to stenting, as well as DEB to LCX. It definitely lessen the metal burden, as well as in long term outcome. I have seen a lot of patients come back with re-stenosis at the LCX ostium, whether you do a DK crush, mini crush, or some sort of provisional bifurcation T or TAP. Lots of patients come with, or
Because
mainly
your experience, Dr. Dhananjay, is actually absolutely bang on with the data which is provided also, where it shows that the L6 ostium is actually the main area of restenosis for any bifurcation stenting. So, Dr. Shaha, your comments, and then we'll wind up the meeting today.
Actually, I missed the last few slides.
Okay.
Sir.
So this was a case of bifurcation stenting with calcium, and I did rotablation in both. And what would be your choice of imaging? Dr. Monga mentioned about IVUS. So do you agree with that?
Yes, definitely IVUS as left main and left main ostium positioning in the ostium. Left main ostium is better held by the IVUS than OCT.
Yeah. I think Dr. Monga had mentioned just in the chat box about the issue about leaving some 1 or 3 millimeter, 2 to 3 millimeter struts into the ostium of any artery. So I think Dr. Monga, what I wanted to discuss and impress was that the thing which you mentioned here about the flaring. So I think the ostial flaring is an absolute necessary thing. If we do not do the ostial flaring properly, then we will have difficulty in re-engagement of the catheter, wiring the artery. So that is something which we need to do. And we have a flash ostial system now. It is actually a catheter where you have three markers. You put the distal marker in the distal part of the stent, the middle marker in the ostium, and the proximal marker outside. And you have two balloons here. One balloon is actually a distal balloon. You inflate it with the inflator, and the proximal balloon you inject 1 ml of saline and something inflate. So that will absolutely crush the flare the ostium properly, and also ensure that the stent is opposed. So that's what I was actually wanting to impress when I told this thing. So flaring, when you're putting stent outside, which is required because it's an elliptical shape and it is not circular, you have to flare. That is a very, very important thing. So that is the point which I wanted to impress on, Dr. Mohammed.
We are doing flaring in all the cases where we are putting stent in the ostium. I thought the question was that if we are having short left main, then balloon side is not available of that side. So for that, I told we can come back in the aorta. Sir.
Absolutely.
That was I was telling.
Yes.
If we have got a 6 mm left main, but what balloon is only of 10 mm or 8 mm, then we can come back little in the.
Because sometimes people sometimes, particularly for the RCA cases, I have seen a lot of people, they don't do the flaring properly, and then they fall into trouble when they go for the next procedure. It's a massive problem. So that is something which you have to do as a part of your procedure also.
Yes, sir. We are doing, sir. Yes, sir.
So thank you very much, all of you gentlemen. And I think it's a puja here in Kolkata. So all of you enjoy. And I also wish the Abbott team who has facilitated this meeting. And obviously, I think we'll ask them to actually do an offline meeting so that all of us can meet up, including Dr. Dhananjay from Patna. Can always come over and we can have a offline meeting after the pujas. So have a good puja vacation and good night, everybody.
Okay,
Okay, sir. Many,
Thank you,
many
sir.
thanks.
Thank you, sir.